Hello and welcome back to the Biochemistry for Health Sciences channel. In the previous video, we talked about how amphiphilic lipids are able to form membranes. And membranes is the reason why we have cells and we have organelles. So in this video, we'll look at another function of amphiphilic lipids, and that's the importance of amphiphilic lipids in our lungs. So once again, just to remind you what an amphiphilic lipid is, it's simply a chemical that has a part that likes water, what we call the head, and then the part that doesn't like water that we call the tail. So here's a head and two tails. And this chemical, this amphiphilic lipid is called phosphatidylcholine or lecithin. So we talked about amphiphilic lipids in the previous video, and just to remind you, so here is lecithin, and here's another type called sphingomyelin. So once again, the head and the two tails, in this case, both tails come from fatty acids, and in sphingomyelin, you have the head. One tail comes from sphingosine, the other tail comes from a fatty acid. But it doesn't matter. Eventually, at the end of the day, we have head and tails. So what's the function of the amphiphilic lipids in our lungs? To understand this, that amphiphilic lipids help reduce the surface tension in our lungs. So what does that mean? Let's look at a solid. So what's a solid? In solid, molecules are held together by their forces, so much so that the amount of empty space is very little. In a liquid, this attraction between molecules is weaker, so they are further away from one another, so the empty space is more. There is more empty space. So that's why it's a liquid. In a gas, the intermolecular attraction is very, very weak, so there's a lot of empty space. Okay, so really the difference between solid, liquid, gas is the distance between the molecules. So if you look at water, and there's so much water in our body, you can see hydrogen bonding. You can see that water molecules, the force that's holding water molecules together is hydrogen bonding. So you can see this water here is being held here, it's being held here, it's being held here, and so on. Okay, so all these water molecules at the bottom of the surface, they all are having hydrogen bonding to one another everywhere, up, down, side, and so on. However, the ones on the surface, you can see don't have any hydrogen bonding above. They only have downwards. You can see all this is downwards. Okay, so basically what's happening on the surface is these surface water molecules are feeling a downward effect. Okay, so they come closer to the molecules at the bottom. So in a way, they start behaving like a solid. The amount of space between the surface molecules and the ones at the bottom is less because of this force that's pulling them downward. And so the surface appears more like a solid. Okay, this is called surface tension. This is called surface tension. So in terms of the surface, you can see it behaves slightly different than the rest of the liquid, which is really more liquid. So this means that the surface of water is slightly different. Okay, so there is a slightly different, behaves more like a solid. And it's a reason why insects can crawl on the surface of water, or why you can float a needle on the surface of water, is because of this surface tension. So in our lungs, we have a cell called the type 2 pneumocyte. Type 2 pneumocyte. It secretes a surfactant, and this surfactant is about 80% of it is lecithin, where the two fatty acids are palmitic acid That's why we call it dipyrimethyl phosphatidylcholine, DPPC, or just lecithin. That's about 80%. Phosphatidylglycerol is about 10%. It's about 2% sphingomyelin, and phosphatidylinositol, another type of phospholipid, is about 2%. So these cells secrete a lot of amphiphilic lipids. And why is that necessary? Because we have this layer of water, right? We have this water which is in contact with air. So there's going to be surface tension here. You see, there's going to be surface tension here in our alveoli. There's going to be surface tension because the water layer is in contact with the air. So the surface of that water layer is going to behave differently than the water layer at the bottom, okay, because of surface tension. So because of the surface tension, the top layer is going to behave more like a solid. That means it'll be more difficult for gases like oxygen to go through solids. Okay, much more difficult to go through solids because of the less empty space in between. And similarly, it's harder for carbon dioxide to go through the solid part. Okay, to travel through the solid part. So remember, these gases already have very poor solubility in water. So if you look at solubility of oxygen, we are talking about only 0.003 mils in 100 mils of blood per millimeter mercury. That means if our PO2 is about 100 millimeters mercury, the solubility is only 0.3 mils per 100 mils. Okay, so oxygen is hydrophobic. It's not very water soluble. Okay, good thing because of hemoglobin, we can increase in our red blood cells to 20 mils per 100 mils. Instead of 0.3 mils, we can increase it to 20 mils, and that's because of the availability of hemoglobin, the remarkable action of hemoglobin. CO2 is also hydrophobic and not very soluble, 0.07 mils per 100 mils of blood per millimeter mercury. So already these gases are quite hydrophobic. They don't like water, and for them to diffuse through this solid layer is going to be a problem. So what surfactants do, they help this solid layer become more liquid, because now these surface layers can start hydrogen bonding to the heads, and so they can start separating from the ones at the bottom. So in the presence of surfactants, the surface of the water layer in your lungs, your alveoli, become more liquid, and that helps the gases diffuse in or out much better rather than trying to diffuse in and out of a more solid structure. There is another possibility why surfactants can help in gas exchange in your lungs. And that is, once the surfactant reaches more than CMC, it can actually form micelles. And remember, the inside of micelles is hydrophobic. Oxygen is a hydrophobic gas. It can stay inside, and so is carbon dioxide. So these micelles can actually trap oxygen and carbon dioxide and help the oxygen diffuse to the blood capillary from outside to the inside. And then from the blood capillary, carbon dioxide can also get out onto the alveolar air. So the presence of these micelles, if the CMC is increased if the concentration of lipid is increased above CMC, this possibility also exists that helps in gas exchange. Okay, so gas exchange is improved by surfactant. One, because the top layer becomes more like a liquid and diffusion is better in liquids than in solids. Two, because of the potential formation of micelles which can trap oxygen or carbon dioxide and help the diffusion across the alveolar membrane into the bloodstream and vice versa. Before we leave this topic on lung surfactant, just a few words about this disease called neonatal respiratory distress syndrome, or RDS. This affects about 20,000 infants per year in the US. And there are many reasons for this disease, but probably the most important is the infant is not producing enough surfactant. Okay, so if you look at this graph here, the lecithin concentration starts rising after the 35th week of gestation and then peaks around full term, 39 weeks. Sphingomyelin doesn't change much. So if the baby is born less than 28 weeks, the chances of getting RDS, the incidence is very high, 60 to 80%. If the infant is born beyond 37 weeks, then the incidence of RDS goes down much lower to 5%. So RDS is also known as hyaline membrane disease. And so what basically happens is because of the insufficient surfactant, there is impaired gas exchange across the alveolar membrane. And that leads to low blood PO2 in your bloodstream as well as in your tissues. You have hypoxia, and CO2 cannot exchange, cannot get out, so there's going to be hypercapnia, increased blood PCO2, and all of these causes pulmonary vasoconstriction. The blood vessels actually get smaller, and that's a inherent property of lungs. So, and this vasoconstriction is going to make this even worse. So this becomes a vicious cycle here, a vicious cycle. Okay, so they start feeding on one another, and then eventually all of this is going to damage the alveolar, the epithelial cells, as well as the endothelial cells that line the blood vessels. So these endothelial cells will be damaged, and these epithelial cells will be damaged. So when these endothelial cells are damaged, then all the proteins in your plasma are going to start leaking out. Proteins such as fibrin, and many other proteins, they will start leaking out. And when these proteins such as fibrin mixes with the cells that are dying, the proteins start aggregating and they start forming this layer that looks like glass. Glass-like. Hyaline means glass-like. Okay, so you get this glass-like layer formed in the airspace. Okay, this is called RDS, respiratory distress syndrome. Of course, that's going to seriously affect gas exchange. So we do actually have a test that is done in the clinical lab to evaluate the amount of surfactant that the infant is producing. These tests are done on the amniotic fluid. So we have a few tests. These tests are useful between 32 to 39 weeks of gestation. These tests must have a very high clinical sensitivity. That means if the baby does have the disease, then the test must be positive. Okay, so you don't want to have a positive test and the baby doesn't have RDS. That's not good. So these tests must have a very high sensitivity. Most of these tests are actually better predictors of lung maturity rather than lung immaturity. So let's look at a few of these tests. One that has been done for many years is called the lecithin-sphingomyelin ratio. So you can see the sphingomyelin remains more or less the same, but around birth, after 35 weeks, the lecithin increases. So if the ratio is greater than 2 to 2.5, the baby's lungs are matured. If the ratio is less than 1.5, then the infant's lungs is immature. Sensitivity is about 50 to 100%. And this test is done by a technique called thin layer chromatography, or TLC. So to increase the specificity, some clinicians started adding phosphatidylglycerol, because you can see phosphatidylglycerol starts rising rapidly, close to birth. So if the PG is greater than 2%, that helps the clinician appreciate that the lungs are matured. So LS plus PG is just combination of lecithin sphingomyelin ratio plus phosphatidylglycerol, which is also typically done with TLC. A newer test is the lamellar body count, LBC. Basically, these phospholipids, these surfactants produced by type 2 pneumocytes, they are produced in lamellar bodies. Okay, these lamellar bodies are the size of platelets. So therefore, they're basically counted as platelets in a hematology analyzer. So this can be readily done by labs because all labs already have the hematology analyzer, and they just use the amniotic fluid and count the so-called platelets. Actually, these are not platelets, but the instrument doesn't know. So the instrument counts the lamellar bodies. Immatured 15,000 per microliter, less than 15,000. A matured baby will have greater than 50,000 lamellar bodies per microliter. The sensitivity you can see is much better. 50 to 100 here, but this is 90 to 100. Okay, much more sensitive than the lecithin sphingomyelin. It should be noted that there are some interferences, blood in the amniotic fluid or meconium in the amniotic fluid can interfere with this test. Some recent studies, interesting, show that these fetal lung maturity tests, or FLM, whether you do an FLM or not, it does not really improve the clinical outcome. So that's kind of interesting. Something you clinicians or future clinicians should read about and consider. Okay, so that is all for now. So we looked at amphiphilic lipids as important role in membrane formation, and now amphiphilic lipids as chemicals that reduce surface tension that is important for gas exchange in the lungs. Until next time, goodbye, and hopefully we'll see you in the next video.